So how you doing? Everything good and you? Dr. Naeem, how are you?
Good, how are you?
We're moving right through this, huh?
Yep. Sure.
Are we over the halfway mark now, I think? Pretty close?
I think so. Yeah.
You get a bit of a break now.
Yes, for anti-coag. Yes. Yeah. So after this, yep. Break. One thing that I noticed, so this slide deck, we have about 60-ish slides, and I noticed tomorrow will be a cute part.
Oh my gosh.
Yeah.
Did we do that? Did we slide into that last year at all?
I don't remember. I just wonder if today is enough, like just to cover all this. We may need to, I don't know if we need to use tomorrow's class period at all,
Yeah.
but
Yeah. Let's see how far we get.
Yeah.
Okay.
Exactly.
All right. Yeah.
Yeah, just something to keep in mind. Yeah, and
And I
things
think here's the thing too. I mean, I think thinking about moving forward, tier one.
You're right.
I mean, I don't know if there's something we can do with AFib just to cover that if we feel like we need to, but I think we can really use that time.
Yes. There's just certain must-know things from that, but I guess it wouldn't take as much time as
we'd have to think about how to structure that, because it's just
you're so right.
Yeah, we need 3 or 4 extra days.
Yeah, you're right.
I think really so. All right.
Yeah.
Well, cool. Well, we'll do what we can, and I'm going to keep that. I'm going to be mindful on that.
Yeah. That's good.
You have an Optima?
Yes.
Okay.
Yeah.
Manda. Say ew. It's touched on my mama's hair, so it's rough.
Your mom's still How old is she? Okay, it's 2:30. Welcome. Nice to see a lot of you today. And happy Monday. Good start to the week. We're kicking it off with heart failure and just the chronic management of it. On Friday, we covered more the background of heart failure, so no drugs involved. But today, it will be a lot of pharmacotherapy, lots and lots of it. And again, we're doing this series integrated, so both myself and Dr. Culhane will cover clinical and science concepts concurrently. So hopefully you all enjoy that. So without further ado, the hope is that we get through everything today that's in the slide deck. And yeah, hopefully that goes well. So just getting right into it, here are our objectives for this lecture. We'll go through the goals of therapy for our chronic heart failure patients. We'll go through some non-pharm treatment options. We will also explain the mechanism of these drugs that we use to manage chronic heart failure, specifically how they can prevent disease progression. And then that will be covered by Dr. Culhane, as well as the structure-activity relationships of drugs. And then we'll go into providing a guideline-based pharmacologic treatment regimen for a patient that presents with chronic heart failure, medications that should be avoided, and then also monitoring parameters. So we'll go through all those details today. Just another form of the objectives, so they outline what we'll be going through, and we'll get right into it. So first and foremost, what do we try to achieve for chronic heart failure patients? We try to relieve or reduce their symptoms, which, does anyone remember what is our primary concern for chronic heart failure patients? Like, what symptom are we worried about? Edema, so which is fluid overload. Yep, fluid status, it's extremely dysfunctional. Any other associated symptoms that you remember? Anyone else? Associated with the fluid overload, like what are some things that patients can have? Shortness of breath, yes. The difficult labor breathing, dyspnea, yes.
Or the ortho, I don't remember, like.
Orthopnea, Yep, exactly. So usage of lots of pillows to not become short of breath and not have like accumulation of fluid in the lungs, right? That affects patients' breathing, makes them uncomfortable at night. And then fatigue, right? So the New York Heart Association, that whole classification, it groups patients according to their symptoms, and 1 through 4, the further along we get, the worse their symptoms are getting. So our hope is that we stop that from happening or alleviate that for them. So that is definitely a primary concern. And then also prevent hospitalizations for exacerbations of heart failure, slow the disease progression overall, prolong survival, and improve quality of life. So these are our primary focuses for our pharmacotherapy. So this staging, it is another form of what we saw on Friday. So that was like in table format while looking at also the New York Heart Association. This is pulled directly from the guidelines. It's just a different way of looking at how the different agents fit in, the pharmacotherapy that we use. So stage A through D, you can see what classes of medications we are pulling in to manage the patient's heart failure. So stage A and B, really, these are not quite at heart failure treatment level yet. You can see these are at risk. What we would do, which is essentially, in simple terms, this is what we do We try to manage patients' comorbidities or other things in order to prevent it to get on to heart failure. Okay, so more like they have risk factors, and we try to ensure that their comorbidities are managed before, it gets to the point of stage C, which is officially heart failure. Stage B is kind of that step right before we get to heart failure, and it's kind of the same approach that we look into as far as our agents go. And then stage C, as I mentioned, that's at that point the patient is confirmed to have heart failure, and that's where our something called GDMT comes into play. GDMT is what I'm commonly going to use to it stands for Guideline Directed Medical Therapy, okay? So that's our abbreviation for all the medications that fall under that umbrella. And as you can see, there's lots. The good thing is that you guys know all of them by now, right? Loop diuretics, I think, were loop diuretics covered already?
Not yet, we'll cover them today, but.
So, yeah, but everything else, with the exception of loop diuretics, you've already seen, which is kind of nice. So you've seen ACE inhibitors, you've seen ARBs. In conjunction to that, those two medications, there's our standalone ARNI, which we'll get into. Beta blockers, MRAs, which are mineralocorticoid antagonists. Does anyone remember what examples? Spironolactone, Clarinone. Yep. So you know that already. And then, SGLT2 inhibitors are new also. So those actually will be covered more extensively in endocrine, if I'm not mistaken.
Yes, absolutely.
Yep. So as far as heart failure treatment goes, I'll go over the clinical things that you ought to be aware of, but you'll get a more in-depth review in the endocrine module. And then certain patients, they would be candidates for some of these treatments. When we get there, I will be sure to go over those. But our backbone, like our main GDMT, consists of the top 5 medications. Our loop diuretic, our ACE, ARB, or ARNI, so it's not all 3, just one of the 3. Beta blocker, our mineralocorticoid antagonist, and SGLT2 inhibitor. So that's where our primary focus really is. That's where we treat these patients primarily. And then you can see stage D is where we get advanced. So this is kind of where there's other measures beyond just pharmacotherapy. We could do transplant in such patients. Maybe they are on mechanical circulatory support, palliative care. It's a little bit different in terms of approach. So that is that. Any questions about this? This is like a super high-level overview of how each subset is approached. So we'll get into the details of each. Okay. This is another figure, and it looks super overwhelming, but it's pretty much what we saw in the previous slide. Again, I pulled this directly from the guidelines. So you can see here on this end, this is where our backbone is for GDMT. So we can see ACE, ARB, ARNI, plus beta blocker, plus mineralocorticoid receptor antagonist, plus SGLT2 inhibitor, plus loop diuretic. It's a lot of medications. This is why I said I love heart failure, because of how much I get to do. Like my job is, I'm super involved with managing pharmacotherapy for these patients, but it's really unfortunate because it's a lot of medications, and from a patient perspective, not ideal whatsoever. You really have to be on top of ensuring that they're adherent, which can be tricky. So that is that. And then, these are just like conditionally recommended, and then, but that's stage D. So that's, just showing the progression of management of heart failure. So that is that.
Dr. Naeem?
Yes.
How about in terms of prospect? Like how much longer a patient that it's adherent versus not adherent? What do you expect them to last? Yeah,
so that's a really good question. It's extremely variable. as far as sticking to these medications, as long as a patient is as adherent as can be, they can live a relatively normal life, which means they have the average adult lifespan, okay? Up to, it also depends on when they're diagnosed, and how much more of a life expectancy they do have. But as far as adherence goes, and as long as it's done near perfectly, then the chances are that they would have a pretty normal lifespan. Things do get out of control though, but as long as they keep in mind what, affects those things, then they can stay on top of it. And by that, I mean like lifestyle things. So things like salt consumption, things like physical activity, staying on top of those types of things because they're extra sensitive to those changes. So, but yeah, that's a really good question. But the true answer is like it is variable. So yeah, kind of hard to answer, but that's the bottom line. Mm-hmm. Any other questions? Okay, we're about to switch gears, go into the pharmacology. About to turn it over to Dr. Tolini.
Thank you. Okay, so we're going to start off again, as I mentioned on Friday. This is going to be our core diagram, the one that we covered last week, that looks at the neural hormonal events that can make heart failure worse over time. So it's like I said before on Friday, it was really important for you to understand this because what you can see here, and I know it's gotten a lot more busy, but what we've done is added in the different drug classes, showing you where they actually work to short circuit this process here. And so all the drugs that Dr. Naeem talked about, with a few exceptions, are shown up here. And again, a lot of them we'll be talking about today, you already had before. A lot of familiar faces and friends today. A couple of new groups, but these are things that you should know. And always, as we look at the bottom line goal for all of these drugs that we're going to talk about here is to help to prevent progression of the disease, which involves cardiac remodeling, fibrosis, cardiac myocyte apoptosis, all of those things that can weaken the heart and further worsen heart failure is what we're trying to do. Okay? So we're going to come back to that for each class of drugs and enter in kind of where they work, and then we'll move on to the next.
All right. So risk reduction strategies. So for these patients, this is applicable to everyone under the heart failure umbrella, stages A through D, as in even those patients that are at risk. And then all the way up to patients that are at the advanced level, we apply the same rules for them. So the goal is that we prevent cardiac insult, aka myocardial infarction, and other structural abnormalities for these patients. We try to control their hypertension and then dyslipidemia in accordance with the guidelines. So if you remember, these are the two primary risk factors for heart failure: hypertension and coronary artery disease, which is essentially it's linked to dyslipidemia. Other conditions leading to heart failure should be controlled and avoided, such as obesity, diabetes, anemia, sleep apnea, smoking, alcohol abuse. ACE inhibitor or ARB therapy, it's recommended when appropriate. So depending on, they have a compelling indication, if you all remember that from hypertension. And then statin therapy is recommended when appropriate as well. So those are some things that we would do. So, yes.
Question.
Yeah.
Since there that there's risk factors for cardiotoxins are risk factors. So if you have a patient with heart failure and you're gonna treat them with doxorubicin, which is like cardiotoxin,
Yeah.
would you not treat them with doxorubicin, or is it patient by patient scenario?
Kind of patient by patient. This is where the discussion of risk and benefit comes into play. So how much of a need do we have to use an agent like that based on, whatever cancer we're trying to treat? If we have alternative options, then that's probably what we would opt for. But if not, then it does become a tricky balance of trying to ensure that we're, avoiding it to escalate to this level or other cardiotoxicities. But yeah, that can be tricky, and antineoplastics can cause things like that from happening, and to some degree it may be reversible, sometimes not. I don't know if Dr. Culhane has anything to add to that.
Yeah, it's been a while since I've taught that, but I think what you said is true. It really is a hard decision at this point, And again, a lot of it depends on the cancer and the chemotherapy regimen, as Dr. Naeem said. And are there alternative therapies that you can use that aren't cardiotoxic? Sometimes you have them, sometimes you don't.
Yeah. Okay, so non-farm interventions. This is hopefully just a refresher of how we talked about managing the other conditions that we've discussed so far in the module. It's a lot of overlap, but the key thing with heart failure is these patients have to keep track of their weight because fluid overload is a symptom, and because of that, there's other consequences because of it. So they have to monitor symptoms of fluid overload and weight daily, ideally in the morning. They should notify their provider if their weight increases by 2 to 4 pounds in one day, or 3 to 5 pounds in 1 week, or if their symptoms are worsening. So that is actually a very accurate counseling point, something that we do tell heart failure patients all the time. That's how they ought to stay on top of any abnormalities. We encourage physical activity as tolerated to improve functional status, smoking cessation if that's applicable, and then limiting their alcohol intake if that's a concern. And then for sodium restriction, so similar to hypertension, which makes sense, right? Because if hypertension is one of the causes, then the goal is to get on top of managing the hypertension so that it doesn't make the heart failure worse. So with that, AHA, they recommend restricting to 1,500 milligrams a day. And this is for patients who are typically in the pre-heart failure stage or at risk. Less than 2,000 milligrams is probably more practical, but you essentially ought to limit as much the sodium consumption. That's one of the direct culprits to making things worse. And then for stage C and D, the general guidance is to just reduce the intake, but you do have these numerical values to kind of go off of. So the goal is less sodium. Try to restrict it as much as you can.
In practical terms, for cookie purposes, you're counseling your patient. How does that look in terms of teaspoons? Do you know what would that look like?
Teaspoons, and compared to this, I want to say it's okay, no, I don't know if I'm right about this. 1 teaspoon? I don't know. Actually, I'm not sure. That's a good question though. Yeah, but the way to track this though is primarily looking at nutritional facts with whatever ingredients you're using, and tracking it according to that. So that's how you would, or that's how patients are counseled on this. But to narrow it down to measurements and exactly what that equates to, I'm actually not entirely sure. Yeah.
Because I was thinking that, for cooking, but it makes sense because a person might use a full teaspoon, but it's not gonna eat the entire thing. So that's why it's tracked that way. Okay.
Yeah.
Makes sense.
Mm-hmm. Mm-hmm. Yeah, that's a good point though. Any questions about this? Cool. Okay, so we'll switch gears back to covering pharmacology. So jumping into loop diuretics and a little bit of their background. Turn it over.
Thank you. And I think I was actually looking that question up, and I don't know if this is correct or not, but about a quarter teaspoon of salt,
quarter teaspoon,
1,500 milligrams. And the real tricky part about that is when we think about salt, we think about adding salt extraneously. when we're cooking but I mean, when you think about all the salt that's in everything.
Everything, yeah.
You know, you just
It's hard.
It's hard. I can't imagine how hard that must be.
It's really hard.
Yeah, that's a challenging part. All right, so let's start with our flow diagram here, looking at the pathophysiologic progression of heart failure here. And the class of drugs we're going to talk about here are diuretic agents. Okay, and specifically we're going to be talking about the use of one of our most powerful class diuretic, which is our loop diuretics. And we mentioned these when we talked about hypertension, but we didn't get into them specifically. Okay. Now, again, the primary role of your diuretic agents is to help to deal with the volume or fluid overload that Dr. Naeem was talking about before. We use loop diuretics because they are incredibly powerful and they work very quickly to help the body remove extra fluid. Okay. They don't necessarily participate in the in short-circuiting or blocking any of the neurohormonal processes that can make heart failure worse, but are really used for symptomatic relief. Okay, everybody got that? All right. So loop diuretics here. I just have a couple of very quick structure-activity relationships. This is our pharmacophoric structure for our loop diuretics. We have an aromatic ring here with substitutions at C1, C2, C4, and C5. Okay, and what I've tried to do is color code these so that you can, when you're looking at these later on, it's very easy. So when you take a look at things like furosemide or bumetanide, there is an acidic group substitution at position 1, typically a carboxylic acid group here that helps to optimize diuretic activity. We also have a sulfonamide group over here at position 5. That is also necessary for diuretic activity and is thought to be an important attachment point for the drug molecule when it binds to the protein transporter in the loop of Henle that it targets. And then over here at position 4, we have an electron withdrawing group, okay, that can vary from compound to compound. And this is also necessary for activity. You've got to have this. And you can change the activity of the compound by varying the strength of the electron withdrawing group. Okay? So again, basic pharmacophoric structure. We have three different important substitution points here that again are critical for the activity of the drug. Now, if we take a look at furosemide and bumetanide, these are two of our commonly used loop diuretics. Let's take a look at furosemide first. We can very clearly see all of the structural features that are necessary for activity, important for activity, on furosemide. So we have a carboxyl group here at C1. We have a sulfonamide group over here at position 5. And position 5, and then at position 4 here, we have a chlorine atom, which is electron withdrawing. So again, all of the necessary structural features. Now, bumetanide is a little bit different. Okay, what we see here is that we have a phenoxy group here that replaces the chlorine atom at position 4. Okay, and the amino group, which we see over here in furosemide, is at position 2. What we do with that is we move that to position 3. Okay, so just a couple of subtle changes. We still have the aromatic ring structure, the acidic group here, the sulfonamide group here. We just move the amino group and we replace the chlorine with a different electron withdrawing group. And what that does, as an example, is that it significantly increases the potency of bumetanide over furosemide. So this is a much more potent loop diuretic than furosemide, okay, just by those two structural changes. Now, in terms of the mechanism of action, remember I told you that the efficacy or how powerful a diuretic is depends on where it works in the nephron. And it also depends on how important that part of the nephron is for sodium reabsorption. So loop diuretics, as their name implies, work in the loop of Henle, okay? Specifically the thick ascending limb of the loop of Henle. So that's the second half of the loop of Henle. And these drugs target a particular transporter protein, okay, called the sodium potassium 2-chloride symporter, okay? So what this protein does is as tubular filtrate or fluid moves through the thick ascending limb of the loop of Henle, this protein binds to sodium and potassium and chloride anions and transports them into the blood, okay? And this ultimately stimulates excretion of sodium and chloride and water, okay, in the in the nephron. So blocking that transporter protein is really important, and we tend to see an increase in sodium and chloride and water excretion from the kidneys. Now, when we take a look at effects on electrolytes, fairly similar, okay, in some ways to the thiazide diuretics, but a little bit different in terms of magnitude. We have an increase in sodium and chloride excretion, okay, which we see with all of our diuretics. We had an increase in potassium excretion. And again, we explore the mechanism by which that happens in the collecting ducts, right? As we inhibit sodium reabsorption more proximally in the nephron, okay, all that sodium flows through the distal convoluted tubule and into the collecting ducts, and then our ENaC channels try to reabsorb that sodium, and as they do, they secrete potassium. So we get a lot of potassium loss with this, and we also get an increase in excretion of calcium and magnesium with the loop diuretic. So again, a lot of changes in terms of the way electrolytes are handled by the kidneys. Okay? Just to show you here an overall picture, okay? Here is the nephron. Right here, in this area up here, is the thick ascending limb of the loop of Henle. This is where our loop diuretics work to block sodium reabsorption. Okay, and if we were to look at a magnified view of that, okay, and take a look at least one of those tiny little cells in the loop of Henle there, we see here is our sodium chloride potassium symporter, okay, right here. And again, we can block that using a loop diuretic. And what happens here is that sodium stays in the lumen here. This is where the tubular filtrate is. It'll wind through the distal convoluted tubule and into the collecting ducts down here. And here in the collecting ducts, the ENaC channels attempt to reabsorb as much sodium and hold on to as much sodium as possible. And as it does that, potassium is excreted. So we actually see a lot more potassium loss with our loop diuretics than we even do with our thiazide diuretics. And the magnitude is different. So again, segment of the nephron, thick ascending limb of the loop of Henle. Molecular target is our sodium chloride potassium symporter protein in the thick ascending limb. And again, changes in electrolytes, increase in sodium and chloride loss, increase in potassium loss, increase in calcium and magnesium loss there. Okay? So kind of similar to some of the other diuretics that we've seen here. Right? All right, Dr. Knight.
Okay, so switching back to clinical roles. So as far as efficacy goes, so as reviewed, help to reduce fluid levels, fluid volume, and improvement in symptoms. The key thing to note with this class or this medication as part of GDMT is they don't help to prolong life. So it's only symptom improvement. All of the other classes, just to give you a heads up, they all prolong life, but loop diuretics do not. That will be a recurrent question that I will definitely ask you all, so be sure to keep that in mind. All patients get loop diuretics with symptoms of fluid overload, and the preferred ones are the ones in bold: bumetanide, furosemide, forcemide. We have an agent called ethacrynic acid, which it may or may not be available. Like at my practice site, it is on formulary. It's used in circumstances where like a patient may have a sulfa allergy. So any of these, like, they may not be safe to you. So ethylenic acid may come into play then, but the ones that I will primarily test you on are the ones in bold. And then as far as safety goes, so you have some background already as to like how some of these side effects may occur. Electrolyte abnormalities are a big one. Loop diuretics can deplete patients of any electrolyte here, sodium, chloride, potassium, magnesium, calcium, because they're taking fluid off. So with that, electrolytes also get excreted and it depletes patients of them. Question?
Just, I need a clarification. When you say no proven effect on mortality, would this mean that if you don't give it to the patient, it doesn't also mean anything?
We are primarily using them to help improve symptoms. So taking the fluid off is what loop diuretics do, but they do not prolong life. Because on a pathophysiological level, they don't work on, they don't work on RAS, they don't work on any of like the activated pathways like sympathetic nervous system, all the catecholamine release, everything that's been covered from that standpoint. Like loop diuretics, they primarily work to take fluid off, but they don't do anything as far as mortality goes. Does that make sense?
A question?
This would not be recommended for a patient that doesn't have symptoms of.
Yeah, so it's not necessarily that every patient is, I would say daily taking a loop diuretic. Like say their fluid status is something called euvolemic, which is they're at their baseline, they're comfortable, no complaints. They're kind of at that point where they don't necessarily need it, and we don't want to dehydrate the patient either. So in those circumstances, we would be prescribing this on an as-needed basis. What that means is like PRN. So like take it as needed as you feel like your weight has gone up or you feel some sort of shortness of breath or your like legs feel a little swollen, things like that. So PRN. But
Can I ask you a quick question?
Oh, yeah.
And maybe this goes along with what Kingsley was asking.
yeah.
In terms of when you look at acute exacerbations, right? When you have someone who's hospitalized and is receiving loop diuretics because they're volume overloaded.
Yes.
In that case, could it save someone's life? I mean, could they potentially die from being volume overloaded? And
I see where you're coming
Yeah.
from. Yes, especially with that like warm and wet subset.
yeah, right. Especially if they're
Yeah.
if they're in the cold and wet, they're hypoperfused and they're very
Then other agents would come into play. So yes, regulating fluid status is just thought to be more of like ensuring that the symptoms are under control, not necessarily like all that's wrong on a structural and like physiological disease state.
So, going to your question, Kingsley, remember, we're talking about chronic heart failure therapy here. So these are medications people will take every single day.
Correct.
And so, again, their primary goal is to, slow down disease progression, right? And in that case, the loop diuretics, they don't do anything. Dr. Naeem's absolutely 100% correct on that. Now, when we talk about acute exacerbations, we do use loop diuretics in emergency situations to help to restore fluid status and get people back on a better Starling curve, or maybe on a better place on their Starling curve. And we'll talk more about that tomorrow. Okay?
So these agents, again, taking fluid off is their primary purpose. But our other classes, those actually there's evidence to indicate that they prolong life. They help to make patients' lives, like they prolong their lives with those who have heart failure. So this is important to convert from one loop diuretic to the next. So this table looks a little intense, but the bottom line, the main thing that you ought to take away from this is this conversion right here. So how to convert from PO or oral loop diuretic to another. So furosemide to bumetanide to torsemide. I do this almost every single day at my practice site. Like I get the medical team asks questions about this on a regular basis with like almost all patients who have heart failure. We do this a lot. So it's very clinically relevant. So in order to convert from one to the other, it's furosemide 40 milligrams, which equals bumetanide 1 milligram, and that equals furosemide 20 milligrams. So that's really the key thing that you ought to remember. I will ask a calculation question tied to this. So yes, something very, very relevant. Just to orient you to the tables a little bit, these dosing ranges, it's more so for your reference, but as Dr. Colleen provided an overview, the most potent out of these is bumetanide, and we can kind of see that with the dosing, right? So the fact that bumetanide 1 milligram can have the same effect as furosemide 40 milligrams or torsemide 20 milligrams, it shows that like with a lesser dose, you still get, you know, an equal or strong enough effect. Another thing to point out to you all is IV and PO furosemide. So you can see there that the IV to PO ratio is 1 to 2. What that means is half of the dose in IV is equal to double that in PO. So for example, furosemide 20 milligrams IV is equal to 40 milligrams of furosemide PO. So exactly half. And that's because of the bioavailability. So furosemide IV is 100% bioavailable, right? Because it goes directly into the bloodstream, but PO is about 50% bioavailable, PO. So you're going to need double the dose, you know, in order to achieve the same effect, or like to be equal. That makes sense. So that's a key difference. Yes?
So does that mean furosemide 20 mg is equivalent to bumetanide 0.5?
Furosemide, yes, correct. Yep, exactly. Yep. PO, yeah. And keep in mind, this is only for PO. So yep. And then just remember that IV to PO for furosemide is 1 to 2. That's the ratio for that. So let's apply this. This is a practice case. So say you have a patient who's on furosemide 40 milligrams IV twice a day, and they have an exacerbation, they're now ready for discharge, and the team wants to send her home on bumetanide. So what would an equivalent dose of bumetanide be? We're going to send them home, so
0.5.
2 milligrams.
okay, let's work this out. I'm going to give you all a second. Let's not yell out answers. Work this out a little bit, because I didn't hear the right answer yet, so. Are we sure about that? Okay, I'm hearing 2 milligrams.
1 milligram. 2 milligrams. Let's try experimental.
I think it's yeah, 8.
All right, total daily dose is
8 milligrams.
8 milligrams?
2 milligrams PO total.
Yes, so total daily dose, not divided at all. Just what is the total daily dose?
80.
4.
4 milligrams.
Oh,
4 milligrams, guys. Okay, let's work through it together. All right. Okay, so I recommend for all calculation problems, as you all saw in CareLab, you should never mentally try to do everything up here. Write it out. I'm telling you, you're gonna make errors otherwise. Imagine we were discharging this patient right now and you sent them out with the wrong dose. Yes. So like initially, what were you saying? 2 milligrams, right?
2 milligrams BD. Yeah, that's twice a
I
day.
didn't hear the full regimen though.
Oh, okay.
I didn't hear the full regimen. The full regimen is if you want to do 2 milligrams BID or 4 milligrams once daily. So just to work through this together, just so everyone's on the same page, and please interrupt or ask if there's any confusion. So furosemide 40 milligrams twice a day is equal to 80 milligrams as the total daily dose. I always recommend just figure out the total amount that you're giving in the day. So that's the first thing. 80 milligrams IV is equal to how much PO furosemide? 40 milligrams, 80 milligrams IV is equal to PO what? 160. 160, right? Double the dose that we're giving in IV. Because PO is half as bioavailable, so we're gonna give double the amount to equal the 80 milligrams IV. Make sense? Everyone following? Okay, so you have 160 milligrams of PO furosemide, right? And so our next step is to convert that to bumetanide. This is where you would set up a proportion ratio. You'd set it up to essentially be 160 milligrams of PO furosemide times bumetanide at the top, bumetanide 1 milligram over furosemide 40 milligrams. Because you have 40 milligrams, which equals bumetanide 1 milligram. So essentially you're doing 160 divided by 40. Does that make sense to everyone? Okay, and so 160 divided by 40 equals 4. So the answer is 4 milligrams of bumetanide total daily dose. Okay. So that is the answer. Any questions? If not, then we can definitely chat about it later, but definitely something similar to this will come up later in the future. So definitely make sure that you're comfortable and being able to convert from one diuretic to the other. All right, now switching to ACEs and ARBs.
Are we to memorize those ratios?
Yes.
40, 120 to memorize?
Yep. Mm-hmm. It's not that bad. It's really not that bad. All right.
And it's easy to practice, right? You can take this and,
Right.
and change around the numbers, right?
Yes,
And
yes.
even the drugs and just test each other.
Yes.
If you do it a couple of times, I think, if I can do
For
it,
sure.
they can do it.
There you go.
Right?
There you go.
All right, now our friendly group of drugs here, just like our friendly neighborhood Spider-Man, we've got our ACE inhibitors and our ARBs. You guys are too young to remember that. At any rate, ACE inhibitors, ARBs, again, block a significant component of the neurohormonal mechanism that leads to worsening of heart failure, okay? You can see here that especially cardiac remodeling, okay, aldosterone, angiotensin II are highly implicated in that process. And so blocking the RAS system, like we've learned about before, can go a long way in reducing the cardiac remodeling associated with overactivation of the RAS system, okay? I am not going over the RAS agents with you. I expect you to know those just from a basic standpoint, knowing your RAS cascade, where do ACE inhibitors work, where do ARBs work, you know, they block aldosterone release and they block vasoconstriction. They also can prevent the cardiac remodeling by blocking angiotensin receptors on the heart. Okay, so again, just using this diagram, you should be able to figure that out. All right, but a very important class of drugs, and that's all I have to say about those.
Awesome.
Okay.
Great. Okay, so as far as their role with GDMT goes, they are pivotal, either ACE, ARB, or ARNI, one of the three. They help to prevent or reduce symptoms, reduce left ventricular remodeling, risk of hospitalizations, and then also reduction in mortality. So these are mortality benefit medications. And they're recommended across New York Heart Association class 2 to 4. As far as safety goes, hopefully this is a review. You all are already familiar with these things. History of angioedema, pregnancy cannot be used in such a state, renal artery stenosis, hyperkalemia. We look out for serum creatinine, especially if it's like higher than 3. And then as far as side effects go, again, hopefully a refresher, dry cough, hypotension, increase in serum creatinine causing acute kidney injury, high potassium, and then potential for angioedema. So that's that. And then in terms of dosing, so there's not a whole lot of difference with hypertension and heart failure. We go about it in the same way. So it's just once a day, usually started off low, titrated to target doses tolerated. And the target doses, they had significantly greater reduction in mortality and hospitalization versus low doses. Now, what it says there, so titrate to target dose, not blood pressure. What that means is that sometimes our blood pressure does become borderline concerning. And what I mean by that is sometimes it is close to like kind of the lower end, anywhere from 90 to 100 systolic to 60 to 70 diastolic. So sometimes we do push it and allow for that hypotensive or like close to hypotensive range, just because we want to ensure that we are optimizing our medication as much as we can. This is again because of our data that suggests that there's a bigger benefit to going up to that target dose. So sometimes there are patients that have really, really soft or lower blood pressures, but if they're not symptomatic, the key thing to look out for is the symptoms. If they have symptoms of hypotension, that's where we can pull back because we don't want patients to suffer because of that. But if not, and they are, don't have any symptoms, they're doing okay, then we keep going as much as we can. Okay. Many patients, they may have baseline blood pressure that's not in the hypertensive range. They may be normotensive, and we still initiate even if the blood pressure is not elevated. So again, to my point, because of the mortality benefit. And then, yeah, the symptoms are kind of where we would pull back. So that's the main takeaway. Like you might be like, well, this patient doesn't have hypertension, so I don't know if we would start an ACE inhibitor. It's a little bit of a different approach for heart failure because, again, our benefit outweighs our risk. The only time we would be concerned is with symptoms. And then,
So since some of the patients are coming with hypotension, would we even consider this at all?
symptoms. The question is, are they symptomatic?
But the patient is already hypotensive because here you see if patient develops hypertension, we should
Symptomatic hypertension.
Yeah, so if the patient is already hypotensive at the point of coming to the hospital, should we consider this at all?
Are they having symptoms? Symptoms of hypotension. If they're not having symptoms of hypotension, we can start off. And I think I already gave you all a reference table to ACE inhibitors, particularly lisinopril. So lisinopril can start at as low as 2.5 milligrams a day, which is an extremely baby dose. But in those situations, sometimes that's what we do. At least we started off, but we started off at a very low point and then ensure that the patient, again, is not symptomatic, and then we go up slowly from there, 2.5 to 5 to 10 to 20 and so on. So that's the key thing to look out for. Are they having symptoms of hypotension? Lightheadedness, dizziness, fatigue, orthostatic hypotension, syncope, any of those things. Those are the main hallmarks of symptomatic hypotension. The number itself, although sometimes it's scary, you see someone with like a blood pressure of 90/60, but they feel fine. You might be like, wait, I don't know if I should do this. But the number is not what our key point of reference would be. It would be their symptoms. So it's a little counterintuitive because we clearly had a different approach with hypertension, right? I remember we went through that and it was very like, if they, start to fall below 90/60, then we will probably want to pull back. But heart failure, it's mainly our concern if they have symptoms.
So in this case, would that patient be an outpatient or inpatient? Where you want to monitor for the symptoms?
So both settings, inpatient or outpatient, they would look out for those things. And when counseling them, when starting an ACE inhibitor, if they're not already on it, you would ensure that they know. If you feel any of these things, then you should probably contact your doctor. You should probably do this as your next steps. So that's the way to approach it. Yeah. Any other questions? That's a good point. All right. So something new that is added to the ACE inhibitor coverage of just the details with that. We cannot use ACE inhibitors within 36 hours of our ARNI agent, which is sacubitril valsartan, brand name Entresto. We need to have a washout period required. You all probably remember this from the top 200 drug abuse sheet. It was one of the counseling points. So hopefully you all remember that. You have an exam this Thursday. So now that you know this, I can totally ask about that now. So this is something new. And this would be applicable, say, if we started a patient off on an ACE inhibitor, and now the patient is in the position to be on Entresto. I say in the position to because Entresto is a brand name medication, which means that it is, actually the generic did come out, but it's still very expensive. Still very expensive. So in terms of access, that's our primary barrier for why patients will not be on this agent. So because of that, if their insurance allows for it, if they're in the position to be, then if a patient's on, say, lisinopril, we're transitioning them to Entresto, we need to wait 36 hours before we do that. And the reason for that is because there's a high risk of angioedema if we use that two agents within that 36-hour window. So we have to watch out for it. And if I'm not mistaken, it has to do with bradykinin accumulation. So yeah, that's like the background for why that 36-hour window is recommended. Like too much bradykinin, high risk of angioedema. We have to space them out by at least this much.
Is there any concern about the potassium too?
Potentially.
Yeah.
Yeah, but then
With the two.
ARBs, so ARBs don't have this rule. I mean, valsartan is a component of Entresto anyway, so it's kind of like ARB to ARB.
Got it. Okay.
Yeah. So, but I think the sacubitril part, when it's used too closely with an ACE, those both are involve bradykinin breakdown. So that can accumulate, and then that could lead to high risk of injury.
And we'll see that. I think I have a diagram on that.
Awesome. Yep. Okay. And then going right into ARBs. So these are pretty much the same as ACEs as we've covered. The main difference is side effect wise, lower risk of dry cough. Like dry cough isn't really a thing for ARBs, as you hopefully remember. And then angioedema, the risk is also less frequent. I mean, it's rare for ACE inhibitors too, but with ARBs, it's like even less pronounced. And then same approach to our ACE inhibitors, low dose, titrate to target dose, literally the same rules apply. And then no washout period is required for our ARB. So if you want to transition from this to our Entresto, then we don't have to wait the 36 hours. That's only for ACE inhibitors. Okay. Questions? Okay. All right. Going on to ARNI.
Okay, so Dr. Naeem has already kind of introduced us to this category of drugs. These are combination agents that include an angiotensin receptor blocker, as we saw before, as well as another type of drug that is referred to as a neprilysin inhibitor. And we'll talk a little bit about the enzyme neprilysin and what it does. So sacubitril here is a compound that will block. It acts on the natriuretic peptide system. I don't know if I have. Let me go back real quick here, just very quickly. So again, remember, just looking at this diagram here. Remember in heart failure, as you start to get an accumulation of fluid in the body and preload starts to increase, as you can see up here, because due to sodium and water retention, and vasoconstriction, an increase in afterload, we start to get an increase in preload, that volume of blood in the left ventricle before it contracts. We know that as that left ventricle stretches, okay, that activates the endocrine function of the heart, and the heart begins to release natriuretic peptides, okay, like BNP, ANP, and those sorts of things. And these hormones, or these peptide hormones, are actually beneficial in heart failure. They cause reductions in afterload. They seem to be cardioprotective and help to prevent some cardiac remodeling that we see. And so, the neprilysin inhibitors are targeted at preventing the breakdown of these natriuretic peptides, as we're going to see. Okay, so sacubitril inhibits neprilysin. This is an enzyme that again is responsible. It's a plasma enzyme. It's responsible for breaking down natriuretic peptides that are released by the left ventricle. And as that happens in the body, the levels of these natriuretic peptides start to build up, which is a positive thing in heart failure. Okay, that will actually reduce sympathetic tone, directly cause vasodilation. The natriuretic peptides do this; they cause vasodilation of the arteries, so we get a reduction in afterload and cardiac work. We also see a decrease in aldosterone release, right? And that is followed by natriuresis and diuresis, so elimination of sodium in water. So there's a type of diuretic effect here that we see that will help to decrease preload. And as we said before, the natriuretic peptides are cardioprotective. So we can see decreases in cardiac hypertrophy, fibrosis, and the other types of remodeling that occurs. So neprilysin inhibitors like sacubitril are really, really helpful in boosting our body's normal, natural levels of natriuretic peptides so that we can see these kinds of effects. Okay? Now, if we take a look at this diagram here, it's a picture of what I just told you, but there's some additional information that's really important and ties right back into what Dr. Naeem was saying before about waiting, 36 hours, I think, to wash out your ACE inhibitor before starting a drug like Entresto. And one of the reasons for that is you can see here's the enzyme neprilysin here, okay? And normally neprilysin will break down our natriuretic peptides, and there's several different types of them, ANP, BNP, and CNP. But neprilysin is an enzyme that also breaks down angiotensin II, bradykinin, okay, endothelin and substance P. And so inhibition of neprilysin, not only does it boost natriuretic peptide levels in the blood, but it also causes increases in these other peptide hormones. Again, with ACE inhibitors in combination with sacubitril, right, you can start to see elevations in bradykinin, especially in the lungs, as Dr. Naeem said. That can be a problem. But at any rate, what we're looking to do with this drug is to boost natriuretic peptide levels in the body. And again, you can see all of these different things that we just talked about on the previous slide, a decrease in sympathetic tone and vasodilation. We get a direct vasodilatory effect of the natriuretic peptides on the arteries. Here's all of the good effects that natriuretic peptides have on cardiac remodeling. And then also they're shown to inhibit aldosterone release, which leads to diuresis and natriuresis. So elimination of water and excess sodium from the body. Okay? Now, the other part of our ARNIs, again, are our angiotensin receptor blockers, drugs like valsartan, for example, is what we see up here. And again, we know all of this here is that our ARNIs will, our angiotensin receptor blockers will block angiotensin I receptors. That leads to vasodilation of our arteries and reductions in afterload. We also get an inhibition of aldosterone release, a decrease in sympathetic tone, and a blockade of the types of remodeling like hypertrophy and fibrosis. So the two of these drugs together, they have very different mechanisms of action, but they have some complementary effects, and ultimately a really great class of drugs to help treat heart failure. Okay. And here again is the just the different things that valsartan will do over here. All these are mentioned on the previous slide here. So you like the diagram, look at the diagram. If you like the text, look at the text. Okay?
All right. So same as before, same as what we covered with ACE and ARBs. We get a benefit in terms of mortality, benefit in terms of reduction on hospitalizations. Pretty much the guidelines now, they emphasize the fact that ARNI should be a RAS inhibitor instead of ACE or ARB. So in the situation that a patient can easily afford being on Entresto, we try to ensure that that's what they are on. If the patients, if they're tolerating an ACE inhibitor or ARB, they should be switched to an ARNI to further reduce morbidity and mortality. The data with ARNI use is incredible. Like, it's really, really good. Patient outcomes are awesome. ACE and ARBs, I mean, it's still, like, they're still under that same class, and mechanistically it makes sense for us to, kind of be on the same, there's, still under that same umbrella, but ARNI, I think maybe potentially due to the sacubitril component, there's like something better associated with that combination. So that's why ARNI is preferred. But in the situation that they can't be, then that's where we would keep them on the ACE or ARB. And then there's like a recommendation for preserved ejection fraction, folks. So again, just as a reminder, like, we've been focusing on those with reduced ejection fraction, that being 40% or less. There's evidence to suggest that there's like benefit in using with preserved or greater than 50%. So with that being said, it's like, maybe beneficial in those patients too. And then this is just a landmark trial that indicates the findings and the benefit associated with ARNI use or Entresto use. And we pretty much found that the endpoint of cardiovascular death or heart failure hospitalizations, they were reduced by 20% in those who were on ARNI therapy. The risk of symptomatic hypotension is the case with this combination. Same with renal insufficiency, greater rate of angioedema. All those things were the case, but then we also see a good amount of benefit. So just kind of have to weigh that or look out for it for those patients. Safety-wise, so same as ACE inhibitors and ARBs. I mean, it's kind of like a lot of them, there's a lot of overlap because they all are under the RAS inhibitor class. And then we have a 36-hour washout period, which was explained. The dosing for this, so it starts off at the 26 milligram twice a day, and then goes all the way up to 97 by 103. It's a little odd. The numbers are a little odd. And then each number corresponds to like the component in Entresto, sacubitril, valsartan. And it's twice a day dosing, so relative to ACE inhibitors and ARBs, as you already know, like, we dose those once a day typically. So this is twice a day. It's a little bit of an adjustment that patients may have to make. The valsartan component has greater bioavailability than the other valsartan tablets on the market, which also adds to its efficacy. It's a little bit better. And then in terms of cost, $500 for 30-day supply. This is like with the brand. Generic is not far off. I think it may be a little bit better, but it's still pretty significant. So for that reason, not every patient is able to afford being on Entresto. That's like a practical limitation that we have. Yes.
With the generics getting into the market now, if the price of the generic is not a limitation, would the choice be to go for Entresto first, or would it still be to go for the ACE and then try Entresto next?
Ideally, we do just ARNI, as in we do Entresto. And then the question there would be, based on the patient's insurance and what the copay ends up being, and if the patient is agreeable to that copay, then Entresto would be our first choice. Yeah. It's all about how much the copay ends up being. Now, ACEs and ARBs, they've been on the market for so long, the copay is not a concern with them at all. But with this, it's a little bit of an issue still. And some patients are agreeable because of, other factors, but some patients may not be. So being on an ACE or an ARB is still better than not being on any RAS inhibiting agent. So that's the goal. Also, I'm realizing we didn't take a break. And I don't know. Yeah, maybe our brain is a little saturated. So I guess this is a good stopping point. We'll take like maybe 5 minutes, come back at like 3:40. Yeah, we'll just take it from there.
Esa no la mando.
Igual está.
Yo, papá, Pasantan Leon.
Leon, perdón, Leon.
¿Ah?
Leon,
12:30 to 1:30? Let me see.
De Valhalla. Valhalla. Eso es el.
Yep. So they have, we're back at 1:30. Yep.
Pues
Okay.
como dio, ¿me entiendes? Los dioses de los vikingos.
Dios te va a saltar.
Valhalla. Para mi primo, esa es el tazo porque es una rampa.
Es que
Rampa volar. Ahí yo no sé dónde. En la abril, yo creo que es paso de. Me saltan las cosas. Y yo quiero dormir. Y me da aquí en Florida. Somewhere, some people in Germany.
A ver cómo es el
Míralo. Se ve como que y mira ahí más hecho.
Sí, es el chino.
Ahí message le cambiaron como arte.
Yeah, she's in Florida.
Está emocionado por no haber hecho los todavía.
Y yo no me gusta.
¿A ti te gusta?
No, yo no sé. Hasta que me acostumbro. Que siento que es que me empieza a acostumbrar. Y a lo que me acostumbro. De Otis. Bueno, gracias.
Okay, it's 3:40. So again, we're on a time crunch, just gonna keep going and hopefully get through as much as we can. This slide, it basically includes the different ACEs and ARBs and then also our Army. And then kind of where we would start in terms of the dose and then where our target dose would be. The ones that are in red, again, I would say being familiar with those is probably helpful. I know I gave these to some capacity for hypertension, but for heart failure, target doses are really important, especially as we're looking at GDMT as a whole. We have to figure out like which ones can we titrate to target dose. So, sorry, there's more clinical utility with that information. So with that being said, the ones in red are the more common, like lisinopril, losartan, common ACEs and ARBs, and then sacubitril, valsartan, and Entresto, just our starting dose and target dose for each. So in what situation would you administer a loop diuretic as needed? When you have symptoms, when there's symptoms of fluid overload, that's basically when, and then administer a loop diuretic multiple times a day. Along the same lines. So essentially the takeaway is for loop diuretic use, it's driven by symptoms. If you're using it on an as-needed basis, that means the patient is experiencing any sort of symptoms of fluid overload unique to where fluid accumulates for them. And then multiple times a day, so they need that symptom relief more frequently. So that's why they have to take it more often throughout the day. Something to keep in mind with loop diuretic use, it is a diuretic, which means that it does make the patient urinate more frequently. So something important to keep in mind is if a patient is on a loop diuretic twice a day, you want to ensure that they take their morning dose and then their evening or like second dose of the day. It's not too close to bedtime. That's going to disrupt their sleep and it's going to cause nocturia. And, it's not the most ideal thing. So you want to ensure that they take it a little bit earlier in the day in case they have that urination side effect. So that's also like something that we counsel patients on with loop diuretics.
And how early would you say, like how many hours before going to bed?
Yeah, so it's driven by the patient, but not too close to bedtime. Usually what I would say, like I've told patients 4 or 5 p.m., and then that way they like still have a couple hours in the day to get it out of their system and
figure themselves out.
Yeah. Yeah. So usually 4 or 5 p.m. is approximately when. And then when would you increase the dose of ACE inhibitor to the target dose? And this is just thinking about what our utility of an ACE inhibitor is.
Not to increase?
When would you? Yeah. Could be blood pressure driven. It could be a lot of things, bottom line. It could be symptom related. It could be that they're tolerating it just fine. We want to ensure that we get them to the maximum, which is for lisinopril, it'd be like up to 40 milligrams. So we keep going until the patient, demonstrates that they can tolerate it. Choose not to increase the dose of an ACE inhibitor to our target dose.
Is it signs of kidney damage?
Sure, yep, so kidney injury, yes.
Hyperkalemia,
Hyperkalemia, absolutely.
angioedema.
Yep. And then something related to blood pressure. So I know we talked about hypotension, but
Symptomatic.
Oh, symptomatic.
symptomatic hypotension, bingo, thank you guys, thank you. Good. Switch from an ARB to an ARNI.
36-hour washout.
Not for ARB.
Oh, arm, oh, okay.
Yeah, for ARB, we don't have to worry about the washout
Oh,
period, right?
Days.
So the main thing with ARNI is what? What is the main barrier to its use?
The cost.
Cost. Practically, we have to worry about that. So as long as the patient is comfortable with the copay that they have based on their insurance for the ARNI, for our Entresto, then we're able to switch seamlessly. So no washout period required, only with ACE inhibitor, okay? And then choose not to switch from an ARB to an ARNI. So just the same thing. Yep, exactly. So if cost is a barrier, then that would be the main holdback. Good. All right, moving right along. Ooh, okay, beta blockers. All right.
Making it doing pretty good here.
Yes.
Okay, so beta blockers. I know I didn't have a chance to talk about beta receptor antagonists during hypertension. We just didn't have the time to do that, but I know Dr. Knighting has talked about them and mentioned them. And they certainly do play an important role in heart failure management, as we've mentioned earlier in the lecture. So when we take a look at the pathophysiologic process here, okay, and we look at all the neurohormones that are involved, okay, that can cause cardiac remodeling, cardiac muscle cell apoptosis, beta-1 receptor downregulation. The sympathetic nervous system is involved in all of that. Those are your catecholamines, okay, that are released by your sympathetic nerve fibers and from your adrenal gland. Now, your beta-1 receptors play a huge role in this process up here. So we're going to start at the top and then work our way down. So we know that one of the key features of the pathophysiology of heart failure is increased activity of the RAS system. And the RAS system activity starts off when renin is released from the juxtaglomerular cells in the kidney. Now there's a couple of different signals that cause release of renin from the JG cells in the kidney. One of them is direct sympathetic stimulation of those cells and activation of beta-1 receptors on those JG cells. All right, so renin release is mediated by the sympathetic nervous system through beta-1 receptor activation on our juxtaglomerular cells, okay? And so a beta blocker here can actually reduce the activity of the RAS system, okay? Another major effect, and not the only effect, but another major effect, is the direct effect of the sympathetic nervous system on cardiac tissue. So we know that in that heart failure pathophysiologic process, that your sympathetic nervous system activity is elevated, and it's elevated over a long period of time, and that exposure, that constant exposure of the heart to catecholamines like epinephrine and norepinephrine can again stimulate cardiac remodeling, that hypertrophy, the fibrosis. It can cause cardiac myocyte apoptosis, okay, or death of cardiac muscle tissue. And it can also cause beta-1 receptor downregulation, which decreases the heart's sensitivity to sympathetic stimulation. So our beta blockers here, again, at lower doses than we would use to treat, let's say, someone with hypertension, actually helps to shield the heart. That's the way I like to think about it. It puts a protective shield or barrier on the heart that prevents your beta receptors from being overactivated. And if we can do that, we can prevent all three of these, or at least reduce the occurrence of these three things here, okay? When I first heard about the use of beta blockers in heart failure, and we're going back to the mid-1990s when it was first, I thought it was crazy, right? Why would you give a cardiac depressant drug, right, to someone who's got heart failure? You know, I do beta blockers reduce heart rate, stroke volume. I'm like, this is crazy. Why would you do it? And, as I learned about it and realized, it's the dose that really matters here, that we're using a lower dose to shield the heart. And there are other effects of the beta blockers as well, too, that we'll talk about depending on which kind we use. All right. So we're going to talk about two different groups of beta blockers here. We're going to talk about our beta-1 selective blockers. These will be drugs like metoprolol succinate and bisoprolol. One of the things that I think is really important to note is that the beneficial effects of beta blockers in heart failure is not a class effect, meaning that it's not, you don't get it from all beta blockers. Only specific beta blockers are used. So when Dr. Naeem talks about their use, you've got to stick with those particular beta blockers that we're going to talk about, okay? Metoprolol succinate is certainly one of them, and bisoprolol. And these particular drugs, what they do is they block beta-1 receptors. And again, they prevent downregulation of beta-1 receptors, which again can preserve the sensitivity of the cardiac muscle tissue to the sympathetic nervous system. They reduce cardiac muscle cell apoptosis, which is programmed cell death, okay? And they also can inhibit or prevent or lower the rate of cardiac remodeling. So these are all good things. In diastolic heart failure, okay, where we have a thickening of the heart muscle wall and a stiffening of the heart muscle wall and difficulty, the heart has difficulty fully relaxing during diastole, okay, beta blockers do their effect on reducing heart rate and actually increase the amount of time that the heart stays in diastole and allow for improved filling time, okay? So keep all of that in mind. They're beneficial in different types of heart failure. Okay? The other group of drugs that we'll talk, the other type of beta blockers that we'll talk about are kind of our non-selective beta blockers across the board. We do have a group of beta blockers that block beta-1 and beta-2 receptors, but these ones we have are drugs that not only block beta-1 and beta-2 receptors, but alpha receptors as well. Carvedilol is one of them, okay? Again, there's the chemical structure of carvedilol, fairly different than some of the other beta blockers. It is, when it is produced, it's made as a racemic mixture, and so the enantiomers have different pharmacological effects. Okay? In the negative enantiomer, we have the beta blocking effects, and in the positive enantiomer, we have the alpha blocking problem. So we get full kind of adrenergic receptor blockade with this particular drug. So very different than like metoprolol succinate, which only blocks beta-1 receptors. Carvedilol blocks beta-1, beta-2, and alpha-1 receptors. Okay? Now, carvedilol is a very interesting drug. We, for years, have classified it as a beta antagonist or beta blocker. Okay? We thought it worked just like metoprolol or propranolol, in that it would bind to beta receptors and sit in the orthosteric site and just prevent receptor activation. But what we found out and discovered after close study and observation of how this drug works is that we found out that carvedilol is actually a biased or functionally selective agonist. Okay? It protects beta receptors from overactivation through this unique effect it has on the beta receptor. Okay, so we start here in the middle. Okay, here we have a beta receptor. Let's say it's called a beta-1 receptor. Okay, and the yellow circle here represents a catecholamine. Let's say it's epinephrine. And when that beta receptor is activated, you get the activation of multiple signal transduction pathways. Okay, you get activation of the adenyl cyclase pathway, as you can see here. Okay. Through G sub S, and then we have the beta-arrestin pathway, which is a signaling pathway that actually shuts the receptor down, sort of like a turn-off switch for the receptor. So the receptor gets activated, beta-arrestin gets activated, and it shuts down the receptor. Okay? A traditional beta antagonist like metoprolol or propranolol or bisoprolol, what it does is it just sits in the orthosteric site here and prevents receptor activation. So that's how those traditional beta blockers work. Okay? Now, if we go over here to carvedilol, carvedilol has a really interesting effect. Okay? because it has this functionally selective or biased agonism, okay, what it does is when it binds to the beta receptor, it actually turns it on. It's not blocking it like a traditional beta blocker does, okay? And when it turns it on, it forces the receptor into a very specific conformation that only allows for the activation of the beta-arrestin pathway, which is the pathway that actually shuts the receptor down, okay? So through activation of the receptor and activation of only one very specific signaling pathway, it actually eventually shuts the receptor down. And we think that effect, okay, is what distinguishes carvedilol from other beta blockers in terms of its effectiveness. We've always known it's a little bit different than some of the other beta blockers, and we think that this might account for that in terms of its mechanism of action here. So very interesting. One of the very few biased or functionally selective agonists that that we talk about in pharmacotherapeutics, but here it is right here. Again, it's a drug that activates the receptor, and when it does, the conformational change that it causes allows for activation of only one signaling pathway, not both over here. Over here with catecholamines, we get adenylyl cyclase activation, cyclic AMP formation, and all that good stuff that goes along with that. And then eventually we also get activation of the beta-arrestin pathway, which will shut the receptor down. Over here, we activate the receptor with carvedilol, and it only activates the beta-arrestin pathway, and that leads to the receptor being blocked or shut down. So a very unique pathway. Yes, Ainsley.
So when it does bring up, when carvedilol is working,
Yeah.
does it also block that receptor? Because if it's acting on the receptor, then other catecholamines cannot act on the same receptor, even though its activity is more agonist.
Technically, you could say that, right? I mean, when it occupies the receptor, it's preventing other catecholamines from. But the difference is, so is a drug like propranolol or metoprolol. When it hits the receptor, it does nothing. This drug actually stimulates or activates the receptor when it gets access to it, and leads to the activation of only the beta-arrestin pathway, which will eventually shut the receptor down. So, yeah, I see what you're getting at there, and technically you could think that way. But again, I think the key thing to understand is that from a mechanistic standpoint, it's a functionally selected biased agonist, meaning that it only allows for the activation of one of those two pathways. So, very interesting observation there. Yes. Other questions about carvedilol?
Dr. Cohen?
Yes, sir.
Is labetalol also, does labetalol have something similar?
That's a really good question. I am not sure how, if they've done those experiments or not. Let me take a look. Let me look it up a little bit. I don't know if labetalol works exactly like carvedilol does, or if it's slightly different and is more of a traditional antagonist. Let me take a look at that for a second. I'll see if I can find. I'll see if I can find something. Okay.
Thank you.
Yep. Good question. All right. So again, carvedilol, beta-1 receptor effects, reduction in heart rate, reduced cardiac workload. Can help prevent some of the remodeling and apoptosis that we see with chronic sympathetic nervous system activity, and the alpha blocking effects of this drug is that we get a reduction in SVR and afterload. And that reduces the work that our failing heart has to do, which is not necessarily, it's actually a good thing. It makes it easier for that heart to move blood through the circulation, okay? I'll turn it over to Dr. Naeem, and let me take a look and see if I can find any information about labetalol. It's a good question.
I actually was just peeking at
Oh,
that.
yep.
It's more from a clinical standpoint,
Yep.
though. So, theoretically, both are non-selective, and there's that similarity, but as far as our landmark trials go with beta blocker use,
Yep.
there's only these three that there's backed up evidence to prove their mortality benefit.
Yep.
Etoposide, bisoprolol, and
Carvedilol.
Yes.
Yeah.
So that's why.
Yeah, it's not a class effect, right? Those are it.
Yes.
And so again, labetalol doesn't fall into that then.
No, there's no hard trial to back up, there's no evidence to back up the fact that it's gonna be this, have the same effect as far as benefit goes. So yeah, just those three that you keep in mind. So as mentioned, there is a mortality benefit with beta blocker use. There's the other, multiple other benefits: hospitalization reduction, reduction of remodeling, improvement in functional status, symptoms, all that stuff. And then only carvedilol, metoprolol, succinate, and bisoprolol have been proven to reduce mortality. That's the key thing. Yes.
Bisoprolol is selective.
Yes, bisoprolol is selective, metoprolol succinate is selective. But yeah, carvedilol is only non-selective. Yep. And then safety-wise, as you all already have a little background on this, so bradycardia is a key concern. We also have concerns for any sort of atrioventricular block, active uncontrolled asthma, especially for carvedilol. Remember, because of it being non-selective, it could constrict the airways in any sort of underlying airway disease. And then acutely decompensated heart failure, which we'll cover tomorrow. Side effects wise, fatigue, bradycardia, dizziness, hypotension, those are some common things to look out for. Okay, so as far as dosing goes, same approach, start low, go slow, that's our slogan. And then we would reduce the dose if the heart rate is less than 50 or if there's symptomatic bradycardia, so also driven by symptoms or hypotension, which mainly occurs with the use of carvedilol because of the blood pressure effects that we can see with it. And then we shouldn't use it in decompensated states. Other clinical considerations are that we don't need to maximize the dose of ACE inhibitor before starting a beta blocker. It's better to be on a low dose ACE inhibitor and low dose beta blocker than high dose of either one alone. So the idea is that with GDMT, it's not like you add one class of medications and then stepwise add the next one and then stepwise add the next one. Like, if you're not necessarily trying to get to a target dose of one and then add the rest, it's all at once, which again can be a little scary, not only from a practical standpoint to ensure that the patient is adherent to all of it, but also with medications that can impact the blood pressure, right? Like beta blocker plus our ACE inhibitor or Arbor Arni, these can have blood pressure effects. So something to keep in mind with that, but we would still do them concurrent. Yes?
So with this in mind, why are we still doing the target dosing?
We're still,
What's the concept of this target dosing when we know we probably want to titrate and then have a mix and match of many things? Why are we still thinking about the target? What does that say? Not thinking of target dosing.
to maximize the benefits that we get from each medication with the class. We can maximize how much of a therapeutic effect we achieve by getting to that target dose. So these medications are studied to work best by the time we get to the target dose. But we have to do it safely, right? We can't just start off with the target dose right off the bat. It has to be done slowly, gradually, make sure the patient tolerates it. They're not developing symptoms, they're not having side effects. We slowly get up to that point. And then the maximum benefit that we achieve is with that target dose. That's what the evidence says.
So in clinical practice, do you like to see patients who are on the target dose for beta blocker for ACE at the same time?
We start off at a low point and then slowly get up to the target dose.
With all the classes?
Yeah. Yes, yeah. And it's a lot. It's a lot to do that. It can be a little scary because, again, some of these do have implications on blood pressure and such. And we worry about side effects too. We didn't get to mineralocorticoid antagonists yet, but that's one, there's a little bit of a different clinical approach with that, which I'll explain when we get there. But yeah, the rule of thumb though is that all GDMT agents are started at the same time. It's not one after the other. Okay, and then here are our beta blockers with their target doses listed here for you. I do have like a handout with all the dosing included in there. Again, it's a good reference to have. So I will post that. I did post a study guide too for this, like my portion, by the way. So that's also readily, like you all should be able to access that. But yeah, anyway, so I was just speaking about these aldosterone antagonists. So we'll cover the science and then get into clinical.
So, Jose, to get into your question, it looks like labetalol is still a traditional equilibrium competitive antagonist. I don't think it has any biased or functionally selective effects. So it doesn't work like carbidopa. Okay? It's got a very different beta blocking mechanism than carbidopa. Not that it matters for this discussion, but it's a great question. And I've often wondered that myself. So there doesn't seem to be any research at this point that suggests that it works like carbidopa does. Okay? It's more like a traditional beta blocker like propranolol.
Even though it has a label of non-selective.
Yeah, well, it does block all three of those receptors, definitely, just like carbidopa does. The way it blocks beta receptors is very different from carbidopa. It acts more traditionally like propranolol or metoprolol. Okay? All right, so let's talk about the aldosterone antagonist. Again, we keep coming back to our diagram here, and the overall goal is to try to block a part of that neural hormonal process that leads to cardiac remodeling and cardiac muscle cell apoptosis and all that good stuff. And so again, spironolactone's effect really primarily is to block the impact of aldosterone, chronic elevated levels of aldosterone on the cardiac muscle tissue. And I keep coming back to this, cardiac remodeling is the big piece here. Aldosterone and angiotensin II are primarily involved in cardiac remodeling. Sympathetic nervous system is as well too, and the sympathetic nervous system causes beta-1 receptor downregulation and cardiac muscle cell apoptosis. But really, the only kind of process here that the RAS system is involved in is cardiac remodeling. Okay, so really blocking that. We talked about again. Here's just a picture of the RAS system. I just put it up there because I kind of liked it. You can take a look at it if you're a little bit fuzzy on the RAS cascade. Again, remember aldosterone is that mineralocorticoid hormone that's released from the adrenal gland. It sits on top of the kidney. And again, remember we talked about eplerenone, we talked about spironolactone, and there's receptor selectivity differences and side effects and things like that. So keep that in mind, okay, as we're talking about this.
So just as an overview, similar to the other classes that we covered, as far as our restriction for when we start this, patients have to have good renal function. So you can see an eGFR of at least 30 and then a potassium of less than 5. Those are two things that we have to keep track of and make sure that the patient isn't hyperkalemic, and if their renal function isn't good, at least above 30, then we shouldn't start them. And then specifically for contraindications, so serum creatinine for greater than 2.5 for males and then 2 for females, or creatinine of 30 or less. And then those with a potassium of 5 or higher. So when talking about, like I previously mentioned, we do concurrently start GDMT, like all agents kind of start at the same time. But one thing that clinically is done a little different with this is we want to ensure the patient is stable and tolerating our RAS inhibiting agent safely, like they're not experiencing hyperkalemia, renal dysfunction, before we introduce our aldosterone antagonist. Because if we start both concurrently, we run into the risk of leading to more acute kidney injury, like worsening their kidney function, and then also increasing the risk of hyperkalemia. Does that make sense? Really want to make sure that everyone understands that. So the general rule of thumb is there is no stepwise approach. You start GDMT all at the same time. But this class of medication, we typically, from a clinical standpoint, we typically wait until it's safe for us to start. Because again, there's the risk of having acute kidney injury with the start of our RAS inhibitor, and also risk of hyperkalemia. And as you can see, we kind of have the same concerns with this class of medications. So we have to wait until the patient is safely, they're not hyperkalemic, their kidney function is stable despite the introduction of a RAS inhibitor, and then we can go about this class. Make sense to everyone?
if the patient comes into the clinic and it's hypocalemic at that point, would you just introduce it?
Hypo or hyper? Low? Yeah, so if they have low potassium, it's, this can help out.
So we just introduce it at the beginning if it's low.
Yeah, then it's probably gonna help out their potassium level. And sometimes that is the case, because, what do you think actually? What do you all think? Why can a patient potentially be hypokalemic? Like think of the other GDMT medications.
Diuretic.
Loop diuretic, yes, exactly. So depletion of potassium can be the case due to loop diuretic use. And so with the like everything kind of evens out with all the GDMT agents. We get, the loop diuretic is decreasing potassium, our RAS inhibitor is increasing, so that this kind of helps to be that like balance in the middle and ensure that everything is kind of normal. But again, it should be done safely. That's the key thing. And as you can see, like there is a mortality benefit with this class. So the goal is to hopefully have the patient on an aldosterone antagonist. And then greatest risk of hyperkalemia, those with renal dysfunction, the elderly, those receiving high doses of ACE/ARB, as we discussed. And then side effects with spironolactone are gynecomastia, which hopefully you all remember that, menstrual irregularities for women. Dosing, so typically 12.5 to 25, we start off with that. Eplerenone starts a little bit higher than that. And then caution for underlying renal dysfunction patients. Make sure that they're not taking anything to increase their potassium with this agent. And then you just have to keep an eye on potassium. That's a key thing to keep track of. So yeah, hyperkalemia is a big thing for this class. Okay, and then SGLT2 inhibitors. Let's see how we're doing on time. 4:11. Okay, 9 minutes. All right. So this is our last class of medications that is in the GDMT group. SGLT2 inhibitors. These are initially they were studied as basically management for type 2 diabetes. And then further studies were done to look at their benefit across cardiovascular diseases. And quite a bit of benefit was found for heart failure. So particularly the two SGLT2 inhibitors that were studied were dapagliflozin or Farxiga and empagliflozin or Jardiance. These are the ones that are currently approved for use in heart failure patients with or without type 2 diabetes, which means that a patient does not need to have diabetes to be on these agents. Okay, so a little different on how that's approached. Initially, they were approved for type 2 diabetes only, but now they can be used beyond that. These help to reduce cardiovascular mortality and hospitalizations, and in fact, these agents there's a benefit for them in reduced ejection fraction and preserved ejection fraction. The evidence for both subsets is great. Like, there's a lot of benefit with this class of medications. So as far as contraindications go, type 1 diabetes, and then having end-stage renal disease. So essentially those who have progressive kidney disease, if they're on hemodialysis, they can't be on an SGLT2. And then renal impairment, that's a big thing. Pregnancy, can't use them. Side effects wise, they can cause urinary tract infections, fungal infections, diabetic ketoacidosis, low blood sugar, again, because they were initially studied for type 2 diabetes. And then acute kidney injury. So kidney implications apply for this class, unfortunately. But for those who can use them, they are awesome. They also are associated with a cost barrier, though, which is unfortunate. So similar to how we talked about Entresto, because these are available as brand, we have a high cost with them. And yeah, that's also something that patients may or may not be able to start with them right off the bat because they cost too much. As far as dosing goes, it's once a day. It's actually 10 milligrams once a day for both. And that's the starting dose and the target dose. So easy to remember. You do 10 milligrams and you stay at that 10 milligrams. And then they're very expensive without insurance, as mentioned. We have to just be careful in renal impairment. May reduce the loop diuretic requirement. This is because they have like a little bit of a diuretic effect. So because of that, like we may be able to pull back on our loop diuretic use. And then should avoid in those at risk of diabetic ketoacidosis or with very uncontrolled diabetes. Okay, and then I think we have just enough time to cover this. This combination, hydralazine and nitrates, it's conditional. So it's only for those who, for African American patients with NYHA class 3 to 4, symptoms despite receiving optimal GDMT with all of those. ACE ARB-ARNI, beta blocker, our aldosterone antagonist, and SGLT2 inhibitor. So essentially, our backbone is checked off. The patient's on all those agents, but the patient's still having symptoms. Then that's where the hydralazine nitrate combination comes into play. It is also applicable for those patients who can't tolerate an ACE inhibitor or ARNI due to renal insufficiency or hyperkalemia. Okay, so those are the two conditions in which we would use this combination.
So when we are using this, are we adding it on top before we say intolerance? Is it an alternative or is it something that can be added on top?
Alternative to a RAS inhibiting agent if the patient can't tolerate that.
Okay, so if the patient tolerates and is not sufficient, do we add this one to the RAS?
Yeah.
So it can be added and it's also an alternative.
Yes, it can be added as long as there's no safety concern. But if there is a safety concern due to our RAS inhibiting agent, then we would add this, or replace it rather. Replace, yep. Mm-hmm. And then in that case, if like renal insufficiency or hyperkalemia is a problem, then our aldosterone antagonist can't be part of the regimen either, because we have the same problems there. So then the hydralazine nitrate would be an option for those patients. Yes?
Yeah, in the first one, so it would put for patients with like the ACE ARNI plus the beta blockers, the aldosterone antagonist and the SGLT1s, like all combined, or only the ACE and ARBs, and you will add the nitrates.
So this is saying pretty much that all 4 of those have been started. The patient is up to target doses for all 4 of them, but despite those 4 being as part of the regimen, the patient's still having symptoms, and that being an African American patient. Then we can add on hydralazine nitrate to help improve their symptoms. And it's specific to African American because that's, again, evidence driven. So the outcomes are proven to improve mortality for that particular race. Now, if you might ask, like, what if we have a different race and we're in this position for them? I think in that situation, we don't know for sure if that's prolonging their life. It probably would help with their symptoms or just as far as like reducing exacerbations, hospitalizations, but I don't know if we have data to prove that it will prolong their life. Whereas for African American patients, we have robust enough data to suggest that the addition of this combination is actually going to prolong their life.
So we need to do more research.
Yes, and this is constantly ongoing. Yeah. So yeah, does that make sense to everyone? Just these 2 conditions. So this is a conditional combination, not for everyone. Oh my God, it's 4:20, almost about to be 4:20. Okay, so let's see. How do we want to go about this? There's not a whole lot left, but I guess like what I would say, let me just make sure. I think the rest of it might be my stuff, which, yeah. So, I would recommend you all like look at the guide that I posted. And then if you have any questions tied to that guide, please let me know. Everything is in the slide deck, so you should be able to locate it, but if you have trouble locating anything at all, just let me know. And we will take it from there. Okay, and then there's some questions, by the way, in this, so feel free to practice with them.